Good afternoon, everyone. We're going to go ahead and get started. So I am delighted to welcome you all to our faculty staff forum. Today we have the honor of having Dr. Jason Beckermann, who is a Mayo physician, joining us. So this is part of our UW-Eau Claire Mayo collaboration. Dr. Beckermann is an acute care and trauma surgeon at Mayo Clinic Health Systems in Eau Claire. He is department chair for general and trauma surgery and assistant professor of surgery. He completed medical school at the University of Minnesota, general surgery residency, and a fellowship in surgical critical care at Hennepin County Medical Center in Minneapolis. And his areas of research interest are trauma and vascular surgery. The title of his talk today is Optimizing Outcomes in Trauma Resuscitation. So we will have some time after Dr. Beckermann's presentation for questions, and I encourage those of you who are viewing online to send your questions to us. Please send them to orsp@uwec.edu. That's orsp@uwec.edu, and our wonderful Max Clark, graduate assistant who coordinates this program, will read those questions aloud. And I will ask you, Dr. Beckermann, when we do have questions from the audience here, if you could just repeat them for our viewers online.
Got it.
That would be great. Then the microphone doesn't pick up the voices as well. And there will be a recording for this presentation posted on our website for later viewing. So please join me in welcoming Dr. Jason Beckermann.
All right. Well, thanks so much for having me here to talk today. This is exciting, and I've, over the past year and a half or so, had a lot of opportunities to collaborate with folks from UWEC, and I'm excited about the relationship that we have together. So this is a topic that's kind of near and dear to me because I did my training at Hennepin County Medical Center, which most of you have lived in the Midwest know that's one of the busier trauma centers in the area. So we did a lot of this, and it's probably the bulk of my practice right now is doing acute care surgery and trauma. So something that I'm particularly interested in. So I don't have any disclosures. My goals today are talk a little bit about the history of blood transfusions, talk about modern transfusion practice, how this has evolved over the past 100 years or so. So when we get to modern, it's changed a lot in the past 20 years or so. And then look at some research that we've done and quality improvement strategies for improving outcomes in transfusion. So why does this matter? When we look at traumatic injury, it's the third most common cause of death in the United States, and it's really been that way for decades. After cardiovascular disease and cancer, it's the most common cause. And when you look at young patients, 15 to 39 years old, it's the most common cause of death. So it is something that's actually has a big impact from a public health standpoint. And where this really becomes important in transfusion is that 30 to 40% of people who die in the setting of trauma die from exsanguination and coagulopathy. Part of this is people, die from massive hemorrhage from their injuries, but what we see in trauma and the patients that we have the potential to save by understanding transfusion science is when people bleed and they have a massive transfusion, they begin to dilute their coagulation factors, they run out of clotting proteins and platelets, and it's really a very frustrating thing as a trauma surgeon when people get into this irreversible stage of coagulation that we call disseminated intravascular coagulation, and you really just watch these people bleed, and there's really nothing we can do to catch up. So we want to stay ahead of that and never get into that situation if all possible. So understanding that science becomes really important. So for those who are not biologists, probably everyone here is to some degree, just kind of where this all fits. Blood is really made up of, in a general sense, three major components. There's red blood cells, plasma, and platelets. Red blood cells are the oxygen carrying component of blood, and hemoglobin. It makes up about 44% of your blood. Plasma, from a transfusion standpoint, is where all your clotting proteins are. I didn't want to put everyone through the pain of the coagulation cascade, how that all fits, but that's a very complex process. And then platelets are about 1% of the blood. So when we look at transfusion these days, and we'll go into this in more depth, but one thing we've learned over the past, 20 years is that the more we can stay away from using crystalloids for resuscitating patients in the setting of trauma, so things like normal saline, lactated bringers, electrolyte fluids, the better that patients do in a trauma resuscitation. And the closer we can stay to giving a 1-to-1 ratio of these items, basically replacing whole blood in the setting of trauma, the better that patients do. So that leads to the natural question of, well, why not just give people blood? And that is the ideal goal. The reality is there's some very practical reasons that it's hard to store blood, it's hard to collect it. There's a lot of waste that goes into that from a blood banking standpoint. So it doesn't work to do that, but we have sort of, from military experience and what they've learned there, shifted back towards trying to use some whole blood for resuscitation. We just don't have a practical way to do it for everybody. So when we look at transfusion patients, we really, for years now, blood has been broken down into those 3 major projects. We use packed red blood cells, we use plasma, and we use platelets. Packed red blood cells can be stored for about 42 days, and then they're, the longer they're stored, the less functional they are, but we can really get out to 42 days. Plasma is really an interesting thing, and this has changed a lot in our trauma resuscitations in the past few years. Fresh frozen plasma is the way that we've used this for a long time. Plasma can be frozen, and when it's frozen, you can store it for over a year, which is tremendous for being able to have large supplies of it. The problem is it's not practical in a trauma setting because it takes about 45 minutes to an hour to thaw it out. And if you have a patient who you're giving them 20 or 30 units of plasma over the span of a few hours, most hospitals have 1 or 2 thawing units for getting this, and what happens is they just can't keep up in the lab fast enough to thaw this plasma out. So while it's a great way to store it, it's not very practical for getting it to the patients in a rapid fashion. If it's not an emergency, it's super. In an emergency, it's not a great solution. Platelets are actually pretty easy. So when we talk about this 1-to-1-to-1 ratio, that we can actually keep up with pretty easily because they come in 6 packs of pooled platelets. So that part's relatively simple for us. Plasma is really the tricky part in trying to keep up. So going back to the history of blood transfusion, when you go way back on this, back in 1667 is the first time that transfusions were described in the literature. Obviously, they did not know much about this back then. They really talked about this as being humoral imbalances. There's this thought process that it was imbalances of your phlegm, black bile, yellow bile, and blood. And when those things got out of sync, if you could bloodlet people or give them blood, they may get better. As you can imagine, that was not very successful. So the reports of this, lots of people died when you gave transfusions because they didn't understand blood typing and those kind of things. And for centuries, this was, there's lots of descriptions of it, but people didn't do very well. Really around the turn of the century, the 20th century is the first time that we saw blood transfusion be successful. And there were really 3 things that drove that. The first one is blood typing, antisepsis, and then blood preservation. Blood typing was really a key step in this. Dr. Landsteiner from Austria was the person who figured that out and actually won a Nobel Prize for this. When I talk about things that are near to me, this is actually kind of interesting. My grandmother was a Landsteiner. Her grandfather, this is her brother. So she used to talk about this when I was growing up, and I have a bunch of articles that she passed on to me. I don't think that really makes me, I don't even have any idea how that makes us related, but in some very remote way, we're connected. But anyhow, this was a very important event in figuring out the ability to transfuse blood was ABO blood typing. Antisepsis was another key thing. Around the turn of the century, Pasteur was promoting the idea of germ theory. People were understanding the ideas that Lister was promoting of using carbolic acid to sterilize the equipment that was being used in medical procedures as well as in surgery, and then blood preservation, the ability to use citrate so blood didn't clot, and then you could store it for longer time periods. And this is still really very similar technology. They've adjusted these, the concentrations of what we use for blood storage a little bit, but that really was a big thing that you could remove blood and store it for long time periods. So when you talk about using whole blood for transfusion, this is just a great picture of early blood transfusions where you have someone standing there, they have an IV in one arm, and they're just letting gravity run, run down into the patient. Transfusing, it's the simplest way of giving a blood transfusion. Like I said, we can't store whole blood for long time periods now, and this obviously isn't a very practical solution, but what we do know is that whole blood works really well for people who are bleeding. And this is where we kind of get to this back to the future thing. In trauma, lots of what we know comes, unfortunately, from wars, because there's tons of trauma. So when you look at trauma surgical procedures, transfusion, there's a ton of literature that comes out of wars, unfortunately. And really, the first time that in a combat setting, transfusion was described to a large extent was in World War I. Dr. Robertson came up with this idea of a Winchester bottle, and we talk about sterilizing the blood and using citrate solutions. This is the first time that they were really able to use it in the field and bring blood out there that could be given to soldiers and used in a large manner. Now, it wasn't super successful even at that point, and it wasn't until World War II that we really started to see on a large mass level that transfusion could be used successfully. Churchill really promoted this in England and the American Red Cross. In World War II, they collected over 13 million units of blood for transfusions to soldiers. Now, there was a lot of learning in that and a lot of failures, but they did gain a lot of knowledge about transfusion and made a lot of progress. And then through the Korean and Vietnam Wars, this got better and better, and there was more use of transfusion and whole blood in particular in combat settings. And that translated into using blood in a civilian setting as well. So sometime around the end of the Vietnam War in the 70s, this all started to go awry a little bit when we look back at the literature on this. There was an idea that came up of rather than using blood, we could use crystalloid. So going to using saline and lactated ringers for resuscitation. And at Parkland Hospital in Dallas, there were a couple of surgeons, Carrico and Shives, who started to promote this idea that you could try to refill the tank in people's third space by giving them crystalloids. And I only put this picture up here because some of you may remember that this is where JFK was brought after he was assassinated at Parkland Hospital. So there's no conspiracy theories or anything like that. but interestingly, that's where he went after he was assassinated, unfortunately. But this idea was like really on the forefront of surgical literature for almost 3 decades, looking at supernormal resuscitation and all these monitors to look at trying to really improve cardiac output and venous oxygenation and how you could manipulate these things mainly with crystalloid and with packed red blood cells. And when I started my residency in medical school, for sure, we really didn't think about bringing in plasma and platelets for patients until kind of they started to get behind and they were already starting to bleed significantly. That's when we would start thinking about trying to catch up. And it's been interesting to watch this over a 20-some year period, how when we get on top of this early, you just see a lot less coagulopathic bleeding and don't get patients that get into that state as often. The other major thing that we've learned and seen in the literature is that people develop less complications from this kind of resuscitation. We used to see tons of patients, we give them so much crystalloid in their resuscitation that they would develop profound acute respiratory distress syndrome. All this fluid leaks out into their lungs, into their bowel. People would develop abdominal compartment syndrome. So it was, I think, kind of an unfortunate time in, like many things in science where things are tried for a long time and you realize, wow, this doesn't work, and has really transitioned. The other thing that happened is that blood fractionization and separating blood into components, just the financial aspect of this, worked out a lot better for blood banking. Unfortunately, there wasn't science to support that, but those are also realities that we deal with. So again, from wars and partially from civilian science, this idea of transfusion with whole blood started to come back into fashion. And what they learned is that when in a military setting, they have soldiers and they know all of the soldiers' ABO blood types, RH blood types, and soldiers are very generous when their colleagues are injured and they're part of the military, that they are willing in massive transfusion settings to come in and give blood on short notice. From a practical standpoint, that's a lot harder to get people to come in from home and donate blood. We have a patient who's massively injured. But what we learned from a lot of literature in this, in those wars, is this idea that giving whole blood is actually better. And then you started to see this idea come through the civilian literature as well. This is what we see now as a massive transfusion pack. So when we have a patient who comes in and we activate what we call our massive transfusion protocol, this is what gets brought up. You get 2 units of whole blood. We get 4 units of packed red blood cells and 4 units of FFP. They put it in an igloo cooler, just like what you might bring to a picnic. It shows up. And that's what we use for transfusing people to get things rolling. So I'm not going to go through all of this in great detail, but suffice it to say, there's been a lot of literature that's looked at this at the past 20 years, looking at how we get, the closer we can get to a 1-to-1 transfusion, matching whole blood, the better that patients do, the less likely they are to die in the setting of massive transfusion. And learning from this literature, I think we've made a lot of progress in trauma resuscitation. This is a really important study that was published in the American College of Surgeons that looked at this exact thing. And what this is really looking at is when you look at patients who get and I'm going to go back a step. So this is from the Trauma Quality Improvement Project. So all the level 1 and level 2 trauma centers, so the biggest trauma centers in the country, enroll patients in this all the time. And it's been really valuable in terms of going back and try to mine data and look at outcomes. And what they found is that when you get a 1-to-1 ratio or 1-to-2, 3-to-1, the more blood that people are getting compared to FFP, the higher the mortality rates. So this is something from all those other studies. You go to the major trauma conferences, we know this as surgeons. I mean, this has become very clear that if we can give more FFP, then patients do better. Now, the problems is this is not as easy as it sounds. It's very hard to keep up with this, and there's some really practical reasons. And when they looked at this study, they went back and looked at this, only 31% of patients in the country who had a massive transfusion protocol were in this range. So most patients, surgeons just aren't able to keep up with this and do what we know needs to be done. So this is a paper that we published this summer looking at some techniques we use to try and get to that 1-to-1 transfusion, and how do we adjust this and hit the bell and optimize outcomes for these patients. So like I said, we know about this 1-to-1 ratio. We're aware of the goal, and we started looking at what are the barriers and how do we actually get there to achieve this. So one of the big things is just situational awareness. When this is all happening, it's a very fast-paced environment. These patients come in, they're really unstable. If you're ever in a trauma bay, there's about 20 people working on this patient. There's lots of blood being transfused right when they come in. When we recognize that they're bleeding, the patients go from the emergency department to CT scan and then to the operating room. And when they get to the operating room, it transitions to anesthesia is the one who's giving the blood versus the nursing staff. And then usually from there, they end up going to a critical care unit. So it's a different team that's monitoring this. And when all this is happening really fast, translating that and getting this passed on of like, how much has this patient gotten when they've gotten 60 units of blood products is really hard to communicate and have everybody understand that. And you'd think that's really simple, but there's so many people, it becomes a game of telephone, what's actually happened here. So that's one of the most practical barriers is just situational awareness. You'd think in this day and age with electronic medical records, you should be able to fix that. And it's all on the computer. Turns out this is very, very hard. Epic is the largest system in the country, and it's really hard to figure this out when you look in Epic. If you go back and try and figure out how much blood has someone actually gotten, it's a real challenge. And then I mentioned this issue of trying to thaw out plasma is just it's a barrier of trying to get it thawed fast enough to give it to patients. And then if we so then you say, well, why not just keep it thawed? The reality is this is an expensive tool. People are giving their own blood to do this. And if we have it just sitting around thawed, there's a lot of wastage, because like we said before, it's only 5 days you have to use it. So you can't just have all your plasma sitting around thawed out. So we really looked at 3 new processes. Like I mentioned, whole blood has become much more on the forefront across the country. We were kind of one of the early adopters, I think, in the country. Well, maybe not the country, but there's many trauma centers that are still not doing this, but using whole blood early in the trauma resuscitation. The other thing that is just an incredibly simple thing that we started using is something called a trauma whiteboard to keep track of the transfusions, and then liquid plasma. This is kind of one of the newer things that's come out, is never freezing plasma. And it turns out it's actually functional for a longer time period, that you can get over 20 days out of it if you never freeze it. And that when they look at the coagulation profile, it's actually probably better than using thawed plasma. So when we talk about whole blood, just kind of comparing the numbers that we had before, it's about 500 milliliters. You can store whole blood for about 21 days, and Mayo has switched to now having this on the helicopters, having it throughout the Mayo trauma centers. This is available to us, and when we start a massive transfusion, that's what we start with, is patients get 2 units of whole blood right out of the chute when they come in. In terms of this trauma whiteboard, this is a Ranger, a massive transfusion unit. I know when you look at this, it probably looks like something from the 60s or 70s, but they're very simple. But in trauma, sometimes simple things are really good. And it's been time tested. And this is for transfusing. A unit of blood will go in here, and the blood gets warmed, and it compresses that bag of blood, and we can, with a good IV, you can get a unit of blood into people in less than 2 minutes. So it's a way to transfuse blood really quickly, and the nurses are running a couple of these at a time, so we can give a lot of blood products really fast in the patient who's bleeding. And we looked at all these different systems for trying to keep track of how much blood we were giving. We looked at the EMR. There's all these like digital systems for this where you can spend thousands of dollars on this, and all kinds of people have tried to develop systems to develop this. And I think it was one of our nurses in the trauma team who said, well, why don't we just go to Staples and get a whiteboard? So it's kind of funny that someone, when we published this paper, said, I can't believe we're publishing a paper talking about using a whiteboard. But this has been super effective, because we just took this thing and we put it on this Ranger, and then this goes with the patient from the emergency department to the CT scanner, to the OR, into the ICU. And now we've actually started using this for patients who have GI bleeds and all kinds of other things where they really need a lot of blood, and it's super effective, and everybody knows exactly where we're at. So this is just an example of this from a patient who got a ton of blood, got 24 units of packed red blood cells, 24 units of plasma. Platelets comes in 6 packs. This is basically 30 units of platelets, and you can just look at this thing at any point, and it's sitting right next to the patient. You know exactly where you're at. So super simple, but it works great. And then switching to liquid plasma. So this is something that we just started seeing come out a few years ago, and it's pretty new literature looking at this, but just never freezing plasma. And if you never freeze it, then we can store it for up to 26 days. The basic science on this is the coagulation profile is probably better than using thawed plasma. They both work well, but it gives us a lot more flexibility. And I was just down in the blood bank asking about this again yesterday, and talking to our blood bank director, and they've just found that we've had very little waste with this 26-day window, and this works really well, and it totally eliminates this issue of having to thaw out plasma. So it's really improved our ability to transfuse plasma quickly. So what we did is, after we had implemented all this, we went back and did a retrospective review. We looked at 20 months of patients before we made these changes, and 20 months after we made the changes. Looked at all of our patients who had massive transfusion protocol, and this is not an enormous number of patients, in any trauma center that get this high volume of blood, but they got 4 more units of blood or packed red cells or whole blood within the first 4 hours after arrival. And these are what we found as results. We looked at the patient's basic demographics. We looked at what their vitals when they came in, and what was their injury severity score, which is, a maximum is 75. So these are, when we talk about injury severity scores in the 20s, that's actually a pretty badly injured patient to see that, which makes sense because you're getting massive transfusion. But these were all very similar in the group, 21 patients before the protocol and 29 patients after this protocol was initiated. And what we found is that using this protocol, we significantly increased the amount of FFP that was transfused per patient. We went from about 4.7 units of FFP up to about 10 units of FFP per patient. And that when we looked at that ratio of packed cells to FFP, we went from about 1.7 per patient to about 1.2. Now, it's still not right at that 1-to-1, but it's a heck of a lot better than what we were doing before. So So in conclusion, this is what we've been able to achieve using these three methods of trauma whiteboard, whole blood, and liquid plasma. We've been able to get a lot closer to using 1-to-1 transfusion ratio in for our massively transfused patients, and have been very happy with this and felt it's been a really successful protocol for us. So open this up to any questions that people have. I'm really grateful for the opportunity to work with people with UWEC. We've had a lot of great relationships with this, working over at the Simulation Center, working with Julie and the undergraduates here, and really looking forward to continuing our relationship as we build the science building and all the opportunities that come with that for collaboration. So thanks for your time today, and be happy to answer any questions.
I have maybe a naive question.
Yeah.
As a molecular biologist, is there such a thing as like synthetic plasma? Or is that,
yeah.
Right? I mean, because
Yep, there is.
We have the blood typing issue in the plasma, right?
Right. Yeah. So there was this. There were a number of synthetic plasmas like hetastarch, polyethylene glycol, I think it was. This was a really common thing that we used when I was in residency. And it turned out that patients actually developed a lot more renal failure when we used that. And there was a lot more problems with acute respiratory distress syndrome. So it really has it was pretty in vogue for a while. So far, people have not been able to replicate that well. But as a volume substitute is where we mainly were trying to use that. But from a standpoint of matching all the proteins in the clotting cascade, there's just nothing like plasma. Albumin is another product that's been used that we use for a lot of resuscitation. It turns out in the trauma patient, there's been large studies that have looked at this, and the patients, when we just give them albumin, have actually higher mortality rates. You'd think from a volume resuscitating fluid it would work better, but the only patient group that we've really seen that be really successful is in patients who have liver disease. But for transfused patients, no.
Coagulants, right? I mean, you can make those all recombinantly, and I can just imagine putting together a soup.
Yeah.
It could be very much like real plasma, but maybe that's a ridiculous thought.
Yeah, it's not there yet in theory. I mean, it could be done, but no one's been able to replicate it yet.
How did your mortality and morbidity rates change pre and post?
Yeah, so we actually saw.
Could you repeat the question?
Oh yeah, sorry about that. How did our mortality rates change pre and post? We did look at that, and there really wasn't a significant. It was statistically insignificant. There was a trend towards improved survival using this, but the reality is when you look at studies of mortality and trauma, you just need such a large number of patients to show that this is meaningful. This is too small of a study. It really takes those kind of large studies where you're looking at national databases to be able to detect a mortality difference, but that's a great question. We were trying to get more at how do you actually do this? We know it works from larger studies, but how do you do it in a successful way?
Did you have a large enough sample to talk about changes in complications or other things you had mentioned? I don't remember all, but how, when you used a certain kind of thing, you had troubles with the lung and others with the abdomen. Were you able to, so not mortality, but morbidity or complications associated with the resuscitation?
Yeah, not in the study that we did. It's too small of a sample size to really see do you have a difference in acute respiratory distress syndrome and abdominal compartment syndrome, renal failure. It just takes too large patient populations to see that. We know pretty clearly, again, I didn't go into this in great detail, but clearly when we use whole blood, the closer we get to 1-to-1-to-1, the lower those complication rates are at. But you really need large multi-institutional studies to show that. But I think that is very clear in the surgical literature.
Are you pursuing a larger multi-center study?
We are not actively involved in one with this, but there are ongoing studies looking at this with whole blood in large studies.
I'm curious, you saw your ratio improve closer to that 1-to-1 but not hit the target, and I'm wondering if you've expect that it could get even better as the practices that with the whiteboard or whatever it might be, that sort of practice piece of it might improve in some way?
Yeah, so the question is, can we get to that one-to-one by continuing to work on this? You know, that's really our goal, and we look at every patient that has a massive transfusion, you know, where were we at? Now we look at this on an ongoing basis. That is the goal. It's kind of a, it's a mindset in trauma resuscitation when you see that patient's hemoglobin is low. I don't know why, but I think it's just so ingrained into us that we have to get that up, and it tends to be people's first reflex is to go to giving blood because you want to get that up. And we're trying to change that mindset, and I think the longer that this is around, the more that people know that matching blood and plasma is the goal. But it's one of those things that's been around for so long that it's hard to move the needle on that. But I think we are really making progress on it.
So I'm sure your numbers were on there, I just didn't see them. So your study was here
Yep.
at Mayo Clinic Health System with trauma here in Eau Claire.
Yep.
And I didn't see what your N was. I was just
Yeah, we had 21 patients in the pre-protocol
Okay, and
and then 29 patients
So
in the
a total.
post-protocol.
about 50.
Yeah. And it really, and that's why this is the kind of thing that needs, when you're looking at outcomes like you're talking
Mhm,
about,
mhm.
mortality, renal failure, ARDS, you really need to have, a lot, they have to be big national studies to really be able to get to those kind of numbers. Even the biggest trauma centers in the country just don't get the numbers to hit that with a single site study. So our goal with this was really trying to give guidance, in what we published, that we felt that this was a successful protocol in terms of improving our results getting to this, and knowing that when you look at this large study that Dr. Netterpelt published in this, when you look at this at a national basis, when they dove into this, this is all the big trauma centers in the country, when they went back and reviewed this, only 31% of patients were in this range of 1-to-1, 1-to-2.
I had a question about this, I'm glad you put it back up. I'm looking at the legend. It's fresh frozen plasma, 2 packed red blood cells.
Yeah.
So 1-to-1 is 1-to-1, but 1-to-2 is 1 unit of fresh frozen plasma to 2 units of packed cells.
Yep.
So why is it as the cells proportionally went up, the mortality rate went up?
Because the reason we think this happens is because you're not giving the elements that are needed for coagulation.
You're diluting.
So you're diluting the blood out, and what tends to happen is you give more you're diluting out your coagulation factors, so people continue to bleed, and they tend to go into this DIC, disseminated intravascular coagulation, where you burn through all your clotting factors, and then they just continue to bleed, and you can't catch up. So the more you're getting out of that mindset of that impacting your clotting cascade is really important in these patients, especially the severely injured patients.
And clotting factors are not yet at a point where they're necessarily medications.
No,
Yeah.
no. There are targeted ones you can give for, for a while we were giving activated factor 7,
Mhm.
so you're giving really targeted, you can give factor 8, there are, and Kcentra, it's a 4 complex clotting factor. They are out there, but that's really, when you look at the literature on that, it's really sticky, and what we know is that blood clots really well the way it's designed. So if we can give back
Yeah.
the real thing, people do better. If we give those targeted agents, so we can use those to reverse specifically, like if people are on medications like warfarin, they're great to reverse those, and you can reverse people like instantaneously. But when people are bleeding out all of their clotting factors, what they really need is plasma.
Mhm. It's nice to know that whiteboards, inexpensive whiteboards from Staples, can make a difference.
It was very funny when this got published. That I can't believe we're publishing a
Well,
paper about.
Again, your ratio pre
Mhm.
was 1 to 1.7, was that
Yep.
right? So you all were doing pretty well before you even changed anything.
Yeah, we were not, you know, like I said, we knew this was a real issue, and we're trying to achieve this, but you always want to get better. And how do you do that? And on average, we're doing really well, but we also would see patients where we totally
Yes, that's
whiffed
true.
on this, where they got way too much. You know, there's a lot of patients where we're right on, we're 1 to 1, but then you'll see patients where they got 3 times as much blood as FFP, and we really want to avoid that.
So in that theme of process improvement, what do you see as the next step or your next goal, or where do you go next?
Well, with this, I feel like with this, we've really gotten about probably as far as we can get right now. Ideally, we'd like to have more whole blood in the resuscitation. I mean, there's some real practical reasons why we can't do that. Well, we've actually kind of moved on to a different project on how we're trying to resuscitate trauma patients. And we just presented this out at the American College of Surgeons a couple of weeks ago. This process called a double 90 protocol that has to do with trying to get patients to definitive hemorrhage control faster. So it's not about the resuscitation, but how do we get them to the venue where we can take care of them quicker. So what we're actually doing is when we have patients that come in and we know they're hypotensive, so their blood pressure is less than 90. If you have 2 pressures less than 90, there's a page that goes out to bring in the backup surgeon, interventional radiology team, and we have a hybrid operating room that's designed for doing radiology procedures, so angiograms, and for operating room. And it calls in all the people because we know that a high percentage of those patients who are hypotensive need an intervention quick. And that's been one of the other big areas in trauma research is how do you get to definitive hemorrhage control quicker. So this is about trying to improve transfusion, but this is what we're really looking at right now is how do we get to stopping the bleeding faster, and that's really a team-based approach. So that's kind of our big target in terms of QI that we're working on right now. So, and interestingly, that's something that Dr. Cerisi, my partner, presented that at the American College of Surgeons, but the moderator for that was from Shock Trauma in Baltimore, which is probably in the top 2 big trauma centers in the country. And kind of interesting, they haven't published this, but they've implemented the same kind of protocol within the past year, doing the same thing, having 2 surgeons there and trying to get their interventional radiology team in quicker. And we've really found that to be very helpful. So hopefully then you're not getting to the point where patients get into DIC and coagulopathic as often.